Today we have Dr. Roy Smith. He's a professor at the University of Pittsburgh. He also practices at the University of Pittsburgh Medical Center. He is a porphyria expert, and he was on last year, and everybody on the Zoom wanted Dr. Smith to be their patient. So I don't think that's possible, but he's definitely a patient favorite. He really takes the time to listen to his patients, and a lot of people sent in some questions ahead of time. So after his presentation, we're gonna answer those questions, and then we'll take some questions for the chat, and then we'll hear from a patient that has acute intermittent porphyria sharing their story, and we'll close down after that. So Dr. Smith, thank you so much for being here today. We're so grateful, and everyone is ecstatic to hear your presentation, and we're so happy that you'll be answering some of our questions. So take it away.
Thank you. This will be pretty brief because I think we should probably get to the questions first. Those are always the more interesting things, I think. But let me pull up my slides, see if I can get them to work. That would be key. Let me know if you can see this.
Yes, you got it. You're there.
Yeah, well, not really. It's the wrong slide. Oh, here we go. Okay, that's my introductions. I really don't have any conflicts of interest here at all. Let's see if I can get this to switch, which I can't. Okay, let me try this. There we go. So as everybody here probably knows, porphyria is primarily a genetic disorder. It can also be acquired. It can be acquired from secondary to various other illnesses like hemolytic anemia, renal failure, hepatitis, various forms of liver impairment, HIV infection, and hemochromatosis. And I would have to say that probably the most common patient I see for evaluation is someone who's sent to me that actually doesn't have porphyria, but they have one of these other abnormalities that make it look like they do. Of those people that have a genetic form of the disease, the genetics involves 8 key enzymes in the metabolic pathway for the formation of heme, and that metabolic pathway is illustrated on this slide here. And I don't want to get too technical about this because it gets to be boring, but if you have a delta aminolevulinic acid hydratase deficiency, a patient can develop ADP, which is a very rare disorder. I've never seen a case of it in my life. Most of the people that I've seen over a 40-year period that I've tried to evaluate for this have ended up having some other reason to have the biochemical abnormalities in their complaints. Usually it's due to lead poisoning or another rare disease called tyrosinemia. Acute intermittent porphyria is due to a defect in the PBG synthase enzyme, also called HMBS. And it results in a buildup of porphyrins as well as porphyrin precursors in the urine, which we'll get to in a minute. Congenital erythropoietic porphyria is a very serious disorder in which there's a defect in the urose enzyme, the uroporphyrinogen synthase, and I'll explain that in a minute. But this is a type of porphyria that you might see on TV or see pictures of on the internet of a person who has terrible photomutilation and hypertrichosis. These tend to be very, very ill individuals. There's porphyria cutanea tarda, which I believe until recently is really the most common type of porphyria, certainly the most common type of acquired porphyria, usually associated with some sort of underlying liver disease. About 20% of them are genetic. There's also the other acute hepatic porphyria, such as hereditary coproporphyria, which is quite rare. I've only seen maybe 3 cases in 40 years. And there's variegate porphyria, which is the second most common acute hepatic porphyria, which is due to a defect in their protoporphyrinogen oxidase enzyme. And then, of course, there is what is emerging as probably the most common porphyria on the planet right now, and that's erythropoietic protoporphyria, which will not be a subject of my discussion today. The pathway is there to produce heme, and heme, as you know, is incorporated in hemoglobin. It's also incorporated in the cytochrome system in the liver, and that system primarily detoxifies drugs and other biochemical byproducts that are cleared in the liver. So anything that stimulates the cytochrome system may result in an increase in activity in the heme biological pathway, which will increase the risk of developing porphyria if you have one of these enzymatic defects. Likewise, if you have some destruction of red blood cells or some stimulus for heme production for the formation of hemoglobin, that can turn on porphyria. Now, the reason for that is because there is a single rate limiting step normally present in this biological pathway. And that's aminolevulinic acid synthase, which is right here. And it, I don't know whether you can see my pointer or not, but it's right here. And what it does is it allows for the combination of glycine and succinyl-CoA to form aminolevulinic acid. And that enzyme, that ALAS enzyme, if it is stimulated, if it's turned on more than normal, what happens is that the porphyrin precursors and the porphyrins themselves are increased until they come to another secondary rate limiting step in which you may have a deficiency in one of the downstream enzymes, which I've just described. As an example, in AIP, acute intermittent porphyria, that enzyme would be HMBS. So what would happen is that because you have increased ALS activity, you have increased upstream precursors that then come before this enzyme, and the enzyme is deficient. It's deficient for various reasons. Sometimes it's, or most of the time, it's due to hereditary causes. And that enzyme is unable to process those precursors, resulting in accumulation in the plasma and also in the tissue, and giving you symptoms associated with porphyria. This is the same rationale that you have for acquired porphyria, except for it's not hereditary. In the setting of hemolytic anemia, because you have hemolysis, you have an increased bone marrow turnover. Red cells are made in the bone marrow, and there's a stimulus to make more of them. So the more that you make, the more there's the opportunity that you're going to overcome the activity of the enzymes in the downstream setting. And so you develop porphyria from that. Renal impairment, very similar, except for in that setting, the downstream enzymes that are precursors that are collecting in the plasma are not ordinarily excreted, and therefore you have them build up in the plasma to the point where you begin to develop symptoms, et cetera, et cetera. See what's next on this slide. I don't know. I just did something wrong. So here are the porphyria types, which I think is sort of an excellent slide provided by the American Porphyria Foundation, explaining that acute porphyrias are acute intermittent, hereditary coporphyria, and variegate porphyria, as well as ALAD porphyria. The cutaneous porphyrias tend to be PCT, EPP, which we'll not discuss today, congenital erythropoietic porphyria, and this rare hepatoerythropoietic porphyria, which is really pretty much the same thing as PCT, except for it's much worse, and it's because it's homozygous. And for that reason, they have a deficiency in the uroporphyrin oxidase, decarboxylase enzyme, and I will explain that in further on in the talk. Some of these are blistering type porphyria, and some of them are they're just simply photosensitive. The blistering type porphyrias would be people that have PCT, whether it be hereditary or acquired, and to some extent variegate porphyria, as well as hereditary coproporphyria. But in general, and not totally recognized, all of the acute hepatic porphyrias can cause blistering if they're bad enough. As an example, acute intermittent porphyria that's homozygous, you can get blistering. Or if you have a severe attack of heterozygous intermittent porphyria, and there's a lot of downstream precursors that are markedly elevated, it's quite unusual. You can actually get blistering changes in the skin. So this slide sort of emphasizes the fact that the two most common acute hepatic porphyrias that are associated with skin changes are the variegate and the hereditary coproporphyria. 60% or so of people with variegate porphyria appear to have blistering lesions. And although HCP is pretty rare, it's hard to know what the frequency is. It's been estimated in some of the literature to be around 20% or so. The interesting thing about this is that when people get blistering lesions like this with acute hepatic porphyria, it doesn't necessarily occur at the time that you have an acute attack of abdominal pain or pain at other sites. It may occur independent of that. And in that case, a patient who has blistering porphyria may be misdiagnosed as having porphyria cutanea tarda or vice versa. So the inheritance patterns of various porphyrias are noted on this slide here. Autosomal dominant with low penetrance is basically the acute hepatic porphyrias plus PCT. It's important to point out that when I say low penetrance, that means that if you looked at the frequency of the abnormal gene being present in genomic studies in large populations, it's quite high. But the actual number of patients that actually have the disease is about 1 to 10% of the total with the abnormal genetic abnormality. And in the case of PCT, the genetic abnormality is quite rare. Only 20% of people that have PCT have it on a genetic basis. The autosomal recessive porphyrias include ADP, of which there's only been maybe 10 or 11 cases reported on the planet. CEP, in which maybe there's been around 200, maybe 220 or so. AHP, which I've just described, which is very rare. I've not seen a case of it. And of course, EPP, which is now probably predominant. And then there's this X-linked type of erythropoietic protoporphyria, which accounts for maybe 20% of the EPPs or perhaps less. So there is this genetic component that can be autosomal dominant, but the penetrance is quite low. So it's possible to have the genetic abnormality and not have the disease. This is why we have to be very careful when we do genetic analyses on patients or populations of patients in interpreting exactly what they mean. In addition to that, we need to be cognizant that when we do a genomic analysis, and we have the capacity to do a genomic analysis on for the entire genome, although it's quite expensive, but we can do it. And there are an entire genome, about 2 million variants of various genes or alleles, and about half of those are called variants of unknown significance. That is, they're not necessarily associated with any disease that we know of. So what that means is that the panel of known variants for the various types of porphyria that we see is expanding constantly. And I presume it's going to expand even more as years go by. So I always get these questions from patients because when we do genetic analysis, we'll come back with a VUS or variant of unknown significance. And the question always comes up, well, what does this mean? And the answer is, I don't know what it means because the data is not there. However, if you find a VUS in a patient that with a known mutation that's associated with porphyria, and they have the biochemical changes associated with it, then it identifies that variant of unknown significance as being important for that disease. And I know at my institution, I've probably in the last 3 or 4 years, I've identified 3 or 4 more variants that are definitely associated with porphyria based upon the patient's presentation. So this slide gives you an idea of what the pathway, what the stages are in heme biosynthesis. It's formation of a pyrrole, which I'll show you in a second. It's assembly of the tetrapyrrole, cyclization, modification of side chains, and oxidation, insertion of iron. The reason this is important is because these changes that I've just shown to you that take place in the heme pathway are the changes that appear to be responsible for the very symptoms that people with porphyria develop. So this slide here is, a slightly more complex slide of the pathway that I've shown you earlier. And the reason I wanted to show this to you is because it gives you an idea of what the chemical structures are that we're dealing with. So glycine and succinyl, under the influence of ALA synthetase, becomes aminolevulinic acid. Aminolevulinic acid then is combined with another ALA molecule to form porphobolinogen, and that's under the influence of ALA dehydratase. Porphobolinogen is a ring structure that has no known biological purpose except for as a porphyrin precursor. When a person with acute hepatic porphyria has an acute attack, sometimes, not always, but sometimes they have a change in the color of urine, and they may describe it as being dark blue or dark brown or even black. And that black color, that dark brown color, that very, very blue color that you see is due to the degradation and the oxidation of porphobolinogen to porphobilin. And the presence of high porphobolinogens in the urine and in the plasma or serum are virtually pathognomonic of the presence of acute hepatic porphyria. Both ALA as well as porphobolinogen have been associated with the neurovisceral symptoms associated with acute hepatic porphyria. And in particular, the ALA has been associated with both acute and chronic central nervous system as well as peripheral nervous system disorders that can be quite severe and can result in chronic changes in the nervous system, resulting in chronic pain patterns that are not resolved by treatment with Hematin or gavoceron. Porphobolinogen deaminase changes the porphobolinogen molecule and allows it to form this linear tetrapyrrole called hydroxymethylbalane. Hydroxymethylbalane has a tendency to automatically want to form a cycle, a circle, okay? And that's circled linear precursor becomes uroporphyrinogen 3, as noted in the lower portion of the slide. Also, it can form what's called uroporphyrinogen 1, and I'll explain that in just a second. The reason this is important is because there's a disorder, a type of porphyria called congenital erythropoietic porphyria, in which there is a decrease in uroporphyrinogen synthase activity, which results in a predominant formation of uroporphyrin 1s or isomer 1s, as opposed to isomer 3s, which are pathognomonic for this disorder. And they play a very large role in the pathogenesis of the disorder itself. And I'll explain that right now. I hope this works. We'll see. So I guess it does work. So here's these chemical structures again. Number 2 here is the linear tetrapyrrole, and it automatically cyclosizes into what we refer to as uroporphyrinogen 1. And if you'll note that this uroporphyrinogen 1 is what we refer to as a symmetrical molecule. The side chains, which are indicated here by these letters, PA, AP, PA, AP, 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 PA, indicates that this molecule is a molecule which is symmetrical in nature. And so what happens is that this molecule is acted upon by uroporphyrinogen synthase, which then alters the molecule. Initially, the molecule itself is flexible. It's a planar molecule. You know, it can wiggle around and move around and bend and flex in the plasma or in the cytosol of the red cell. But once it's acted upon by uroporphyrinogen synthase, what happens is there's a flip that occurs in one of the rings of the molecule, and the molecule becomes very, very inflexible. And that allows the molecules to stack upon each other. They layer like a bunch of pancakes sitting on top of one another. And that allows the next enzyme to more efficiently alter that molecule. So for that reason, what you see in people that have CEP or congenital erythropoietic porphyria is the buildup of the degradation products of uroporphyrinogen. But those degradation products are primarily isomer 1s. In Porphyria cutanea tarda, which is characterized by a deficiency in the activity of uroporphyrinogen decarboxylase, that same process takes place in terms of the degradation of the uroporphyrinogen molecule. But in that case, it's much more efficient because the molecules are stacked upon another and they're readily available for enzymatic activity. And in addition, what happens is that when the urod molecule is deficient, you get a buildup of the breakdown products of uroporphyrinogen. I'll show you that in a second also. So in people that have CEP, you have a buildup of all these uroporphyrinogens, and the breakdown products are isomer 1s. And these isomer 1s float around in the serum and the plasma and in the red blood cells. And wherever the blood goes, these isomers go, and they're deposited in the tissues. These are in very, very high concentrations, and these high concentrations result in patients having super photosensitivity, which gives them mutilation over time. They will lose their tips of their nose, their ears, their teeth will fall out, their teeth will turn black. They will often lose bone where they have mutilation of their hands. Their sclera in their eyes and their conjunctiva are affected. And over time, if they're not cared for appropriately, they can go blind. They can develop renal failure, severe hemolytic anemia, because the red cells are being destroyed by the presence of these isomer 1s in the red blood cells. And because of that, they develop large spleens and may require a splenectomy to be done because of a painful spleen or early satiety. It's a disease that is in its worst form, can be absolutely devastating. However, when it's mild, it can mimic a patient that has PCT. And I'm going to show you that in a second, maybe. So the next step in the pathway is effective uroporphyrin decarboxylase. And what that does is that takes this uroporphyrin molecule, either of the 3 isomer or the 1 isomer, and decarboxylates it, as the enzyme says. And what that looks like is, hopefully it looks like this, okay? So you have a uroporphyrin molecule that has 8 side chains with carboxyl groups on them. And what happens is, one by one, a carboxyl group is removed from each one of the molecules. The enzyme works going in a clockwise fashion around the molecule itself, okay? And so when you have a person that has CEP or PCT, you have a buildup of these intermediate molecules. The uroporphyrins will be elevated. The heptos will be elevated. Less so will the hexos. Less so will the pentos. And finally, you'll have the coproporphyrins elevated. This pattern is seen in both people with CEP as well as PCT. But with CEP, there's a dominance of the 1 isomers. So the concentration is much higher than the 3 isomers. And the reverse is true for people that have PCT. The other thing is the patients that have PCT have less of a concentration of these abnormal molecules. These abnormal molecules, if you look at them, they have these little lines in this, in the middle of the individual's rings. Those molecules are supersaturated. Those are covalent bonds, and that gives these molecules the property of emitting high energy when they are stimulated at a specific wavelength of light, and that wavelength is called the short wavelength, which is a wavelength of 400 to 410 or 420 nanometers, and they emit energy at a much higher energy level. That energy level that they emit it at, depending on the underlying disease, is around 620 nanometers. It's the emission of that energy that burns the skin and causes the mutilation in people that have CEP, and also the minor mutilation that you may see in PCT. This is the source of the pathology of people that have these types of porphyrias. Furthermore, these molecules take on a reddish color. They're pinkish red. And so when you see a patient's urine who has porphyria, it may be pink, it may be dark blue, it may be black, it may be dark brown, or it may be purple. And as you know, the primary colors of blue and red form purple. And that's where the disease gets its general name, porphyria, okay, means purple. So at times you can have a patient that has acute hepatic porphyria, in which for some reason, and I'll explain this in a minute, may have very high levels of the molecules that you see here on the screen. And their urine is pink or red. And there's other times when they may have acute attack that is very, very severe, which porphobilinogen levels are very, very high in the urine. And for that reason, their urine is dark purple or brown. Let's go back to this other slide again. So, urod or uroporphyrinogen decarboxylase alters the side chains of the molecules. And the end game of this is that you form this thing called coproporphyrinogen 3. Coproporphyrinogen 3, and also 1, by the way, are molecules that we refer to as being amphiphilic. Amphiphilic means that they have a shared solubility with water, and they are also partially insoluble. All the molecules from coproporphyrinogen and downstream from that become less and less soluble. The solubility is based upon the number of carboxyl groups. So as you cleave off a carboxyl group from your uroporphyrinogen, and you form hepta and hexa and hepta and penta, all these things become a slightly less water soluble. By the time you get to the copra, it's very much less water soluble. And when you get beyond that, they're fundamentally totally water insoluble. Okay, so what happens is these less soluble molecules are excreted in the bile. The bile have micelles in it that allow insoluble molecules to pass out of the bile into the GI tract. And this is why when we are working up individuals that have porphyria, we often want to obtain a stool sample. And the reason for that is because you get a concentration of these non-soluble molecules in the stool. As an example, in a person that has CEP, there's a very high concentration of coproporphyrins in the stool that is beyond that you would normally see in the urine. All right? So the next step is the oxidation of coproporphyrinogen by CPOX, or coproporphyrinogen oxidase. The important thing about this enzyme is that it only acts upon the 3 isomer. So the 1 isomer cannot be evolved any further. And so it has no biological significance other than the fact that it can cause this pathological development with Porphyria cutanea tarda and with CEP. Protoporphyrin 9 is the pre-molecule to the formation of heme. This molecule, as well as the uroporphyrins, and probably also the intermediate porphyrins between the uroporphyrins and the protoporphyrins, are all molecules that can be found in the liver if you have acute hepatic porphyria, or predominantly in red cell precursors if you have an erythropoietic porphyria. They are actively transported out of their cell, out of the cytosol of their cell. There's specific transporter molecules that are ADP dependent, they're energy dependent, which will transport protoporphyria, or I'm sorry, protoporphyrins out of the liver and out of the red blood cell. Likewise, there's another type of transporter. Again, it's energy dependent. So it's an active transport system that will transport the other precursors out of the cytosol of cells. In the case of people that have CEP, and presumably also PCT, although I don't know that for sure. There is evidence that one of these transporters is abnormal. It's decreased, it's absent from the red cell surface and from the liver cell surface, the hepatocyte surface. And for that reason, these molecules get trapped within those cells. They get greater and greater concentrations. If they're in red blood cells, they cause the cells to be destroyed, they hemolyze, and you develop severe anemia. In the liver, okay, they build up. We can see this. We can stain the liver and see these molecules actually in the not that molecules, but they're needles of the molecules, concretions of the molecules in the hepatocyte itself, in the liver cell itself. And that results in damage to the liver and may predispose patients to the development of hepatocellular carcinoma at a later date. An abnormality in the insertion of iron into protoporphyrin 9 results in this type of porphyria called EPP, which is characterized by a predominance of metal-free protoporphyrin being found in the red blood cells, and also a completely different emission pattern that you see with the other type of porphyrias. And I'll get to that in a second. So this is a schematic, which I really like, of the same thing that I just showed you, only it's less complex. But what it does show you is if you look in the middle of the slide, you'll see these bars that are sticking up with different colors that match different types of acute hepatic porphyria. And what you'll see is that just above ALA, that if you have AIP, the AIP, the ALA would be quite elevated, whereas it would be less elevated in patients that have HCP or variegate porphyria. This is a pattern that's seen in the urine and is also seen in plasma. Now, the reason we don't measure plasma usually anyways, and people have acute hepatic porphyria, is because these things are concentrated in the urine, so they're more accurate in the urine itself. If you look at the porphobilinogen, which is, this is PBG here, what you'll see in AIP, they're very, very high, and they're elevated also, but less so in HCP and VP. Since ALA is, porphobilinogen is made of two ALA molecules. What normally you see is the pattern as demonstrated here, and that is that PPG is twice as high in concentration than ALA is, okay? So that means you could have a person that has acute hepatic porphyria, has an acute attack, but it's not very severe. PPG goes up, but ALA is not detectable. And that's why we prefer to look for porphobilinogen in the urine and the plasma rather than elevations in ALA. I mean, sometimes we do, but normally I don't, okay? The other reason I don't is because in people that have ALA dehydratase deficiency and porphyria, they always have an increase in total porphyrins in the plasma and the urine. So there's no reason to look at ALA as part of a screening test. Furthermore, for a patient that has an acute attack, which they think is an acute attack of acute hepatic porphyria, it is literally impossible for a person not to have an elevation in porphobilinogen and total porphyrins. It's literally impossible. Now, that elevation may vary depending on the severity of the disease. So it's possible that you might have an elevation in total porphyrins and the porphobilinogens be barely detectable. Also, there is a debate in the medical literature about what a significant elevation in porphobilinogens really means in the urine. What's the cutoff? It varies from laboratory to laboratory. As a result of that, many of us feel that that our cutoff is when the porphobilinogen levels are greater than 5 times the upper limit of normal. The reason for that is because if a patient is dehydrated, then you can get trace amounts of porphobilinogen detected in the urine, and they look like they may be elevated, beyond the normal values, which is varies from lab to lab, but it's usually about 0.2 milligrams per deciliter of urine. But at any rate, so we sort of have this cutoff of 5-fold increase to try to eliminate a misdiagnosis of a person having porphyria just simply because they're dehydrated. All right, so the other thing about this slide is, as you can see, as you go from the left part of the slide to the right part of the slide, you then have a predominance of the downstream precursors. So on the left-hand side of the slide, you would expect the urine to be dark blue or sort of brown. And on the right-hand side, if the urine is abnormal at all, you would expect these people to have more of a reddish urine. Well, that's textbook stuff. The reality of the matter is, most of the patients that I see with porphyria, at least when I see them, don't have any changes in their urine. Now, that's not to say they don't have it. It's just that they don't have it when they're in my presence. It does take a while for the urine to change colors. It can take a couple of hours, and it can take up to 3 or 4 days for that alteration to take place. Also, what's demonstrated in this slide is if you have a hereditary coproporphyria or variegate porphyria, what you see is that you have an elevation in the fecal copras and protoporphyrins, okay, as I described earlier. So that's why we tend to look at a fecal sample, is to be absolutely certain that we're not dealing with one of these types of porphyrias. Now, let me move on here if I can. I'm taking too much time with this, I think. So acute hepatic porphyrias sort of share common presentations. They have unexplained abdominal pain. They may have unexplained projectile vomiting, constipation, insomnia, agitation, hallucination, seizures, peripheral neuropathy, hyponatremia. They can have cardiovascular instability, and of course, the change in the color of the urine. These things are brought on by stress, caloric restrictions, various medications, and sometimes during the luteal phase of the menstrual cycle, or when women are beginning oral contraception, combined oral contraception. As I've said before, well, here, let me show you this first. So this is one of many panels you can get off the internet and elsewhere about what the presentations are for people with acute hepatic porphyria. But I wanted to point this out because 85 to 95% of people have abdominal pain, and that's been my experience also. But what I wanted to point out was that if you look down here, if you look a little bit lower in the graph, what happened to it? If you look a little bit lower down here in the graph, you'll see that 50 to 70% of people present with non-abdominal pain. Isn't that interesting? There was a paper that was published in the medical literature several years ago looking at the frequency of acute hepatic porphyria in patients that had been diagnosed with fibromyalgia. fibromyalgia is one of those sort of garbage can terms that people use all the time. When some patient comes in, it's usually a lady, comes in, they have unexplained pain and they have trigger point reproducibility of their pain. And so they're labeled as having fibromyalgia. But it turns out in this paper that about 20% of people that have that actually have acute hepatic porphyria, and they're presenting not with acute abdominal pain that takes them to the emergency room, but they present with this chronic pain around their neck and their back and their thighs. So keep that in mind, because although abdominal pain is really the predominant thing, at the same time they may have this chronic pain, or the chronic pain may be there without the abdominal pain. And how can that happen? Well, it's because if you have high levels of ALA and porphyrobilinogen, you have nerve damage. It is acute. You get an acute neuritis, that's giving you the abdominal pain. But you can get chronic neuritis because the nerves are irreversibly damaged, and that gives you this chronic pain. You can also develop an ascending paralysis, very similar to what we refer to as Guillain-Barré syndrome, in which you have peripheral neuropathy with decreased muscle function that ascends up your legs, up your abdomen, into your arms, and then into your chest, and you have difficulty breathing, need to be placed on a ventilator, and you will die if you're not appropriately treated. It can also cause seizures in about 10 to 20% of patients. And what I consider to be the most common thing I see is brain fog. And that is where you cannot think normal. You can't balance your checkbook. You can't take care of your kids normally. You can't cook a meal, or something like that. And I see this constantly in people that have an acute attack of porphyria. Let's go back to their slide again. So I want to make a comment about the cutaneous manifestations. And here's the comment I'm going to make. And that is, as I said, there's blistering porphyria. And we think of that as being PCT, porphyria cutanea tarda, variegate porphyria, again in about 60% of patients, HCP, frequency unknown, but maybe 20%. But you also get it in severe AIP, homozygous AIP, or you would see it in a person with AIP that has renal failure, okay? And you can see it in severe EPP. I've got a patient with this right now, with EPP that's blistering like crazy, and he has a very severe form of it. You can see it in the absence of abdominal pain for the reasons that I've told you already, and that is that there's a predominance of these downstream porphyrins that sensitize your skin, and less of an increase in porphyrobilinogen and ALA, which causes the nerve damage and the pain. You can also get a presentation with redness, edema, tingling, pain, but with almost no change in the skin at all. And you would see this in people that have mild EPP or XLP, and sometimes you might see this in people with porphyria cutanea tarda, in which they don't actually blister, but they have this photosensitivity and they just can't explain it. There's this nothing there just to look at. Eventually, things do appear, but it is part of the differential diagnosis to think of these abnormalities. And then there's the photomutilation that occurs with CEP primarily, but can occur with severe porphyria cutanea tarda and EPP also. Okay? Therefore, patients with cutaneous manifestations may require a total workup for all the various types of porphyria that we've just discussed. And I tell my fellows and my residents and my colleagues, you have a patient come in with porphyria, do not stand there and take their word for it for what they have. Don't listen to them and have them point out the blisters on the surface of their hands and I have PCT. Oh, no, you can't do that. You have to completely evaluate them. All right, I'm coming to the end, thank God. Maybe. Okay, so in acute intermittent porphyria, the defect is the HMBS gene, and 50% of the time you have a defect in both the erythroid HMBS and the non-erythroid HMBS. What this means is that you can have you can have a defect in HMBS in hepatic and non-hepatic tissue. All right, this is important. And the reason it's important because acute hepatic porphyrias are thought to be primarily hepatic disease. And one of the potential therapies for people that have severe disease is to do a liver transplant. Theoretically, it's curable, but nothing's perfect in medicine. And we do have cases of people that have gone through hepatic transplant for severe AIP, in which after the transplant is completed, they still get the pain and they still have these abnormal porphyrobilinogens appearing in their urine. And it's likely that this is due to the fact that these people have two genetic defects, one in the liver and one in the erythroid elements, in the red cell precursors in the bone marrow. And it is actually derived not from the liver itself, but from the bone marrow. The same thing may occur in people that have CEP, and that is a bone marrow transplant theoretically should be curable. But we have evidence that in pediatric cases that there is buildup of the isomer 1s in the liver, and those isomer 1 buildup that we see may be de novo from the liver itself. All right? So keep that in mind. So how do you test for this then? Well, you know, the urine porphyrobilinogens are highly sensitive, highly specific. I tend to use a random urine sample, and the reason I do is because 24-hour urine samples are very difficult to collect, especially among ladies because of the inconvenience. Almost everybody loses a part of the sample, so which always draws into question as to whether the sample is accurate or not. If you know your laboratory well, you can talk to the laboratory technicians or the physician in charge. What I use is the upper limit of normal in that laboratory. If not, then I use 5 times the upper limit of normal to be sure that I'm not being caught up with people that have either dilution of their urine or are dehydrated and have concentration in urine and either missing acute hepatic porphyria because of dilution or overdiagnosing it because of dehydration. Serum testing is always available, but it's really only indicated in people that can't produce urine, those people that have severe renal failure. Total porphyrins, I always measure. It's part of the screening test, and I do that because except for the EPP and the XLP, total porphyrins are always elevated in the urine during an acute attack. Okay? So one of the things I should point out to you is not only is the ALA concentration half as much as the porphyrobilinogen concentration is in the urine and the plasma, but there's a difference in how long these abnormalities occur in the plasma and the urine. If you have acute intermittent porphyria, porphyrobilinogens will stay in the urine and the plasma in an elevated concentration for usually months to even years. 30% of people that have acute intermittent porphyria, the porphyrobilinogens remain elevated for what looks like a lifetime. If you have variegate or coproporphyria, the total porphyrins remain elevated for several weeks, and the porphyroblinogens become normal in usually less than a week, week and a half. So it's possible that you could have a person that has acute hepatic porphyria, has an attack, and you get a sample, a week later, and the porphyroblinogens are negative, but the total porphyrins are positive, and you're going to look at that and you're going to say, well, this patient doesn't have acute hepatic porphyria, when they actually do. So you have to be careful about that. The other thing is, I only use one laboratory for my patients, and I only use one laboratory for a reason. And that is, I want to be sure my samples are sent to the appropriate laboratory in the appropriate way, and that they're collected properly. And on the other end, that they're appropriately taken care of. And what I mean by that is that these porphyrin precursors and porphyrins in the urine and plasma are unstable. They oxidize fairly rapidly. And if you have a sample and you leave it sit out at room temperature, you will lose 20% of its activity usually within 24 hours. If you leave it sit out in the light that has a blue range in it, and that's sunlight, fluorescent lighting, and some incandescent lighting, then you'll lose about 50% of its activity within 24 hours. So I want to be sure that from my end, that these samples are taken care of carefully, and I want to be sure that when it arrives at the lab, that they're not, the package is not sitting someplace on a desktop open and exposed to light or room temperature. So I only use one laboratory because I think it's reliable. So acute hepatic porphyria is a disease that, in general, there's only one attack in a lifetime. And it's mostly in women. And the reason it's in women is because of the menstrual cycle during the luteal phase. It's thought that almost 90% of people that have acute hepatic porphyria have only one attack, only one. And often people don't remember having it. At least they spontaneously don't remember having it. Many women have it at the time of their very first cycle, and they confuse it with, onset of menses. Others have multiple attacks a year, and those are usually the type of patients that I see. Now, the significance of this is that acute hepatic porphyria may be much, much more frequent than we think. The frequency of a pathologic variant for the HMBS gene is 1 in 3,000. The frequency of the disease is about 10-fold lower than that. Okay? It's about 1 in, I don't know, depends on what literature you read, 1 in 30,000, 1 in 50,000. That's somewhere in that range. Depending on what population you're looking at. If you're in South Africa, variegate porphyria is very, very common. If you're in Scandinavia, AIP is very common. So anyways, people I see are people that have lots of painful episodes. And in this setting, when you have a painful episode, what I always do is I get a urine sample from them. I started them on hemotin. I don't bother with glucose infusions. A lot of people do, and that may be the case in people that have mild disease, but in people that have acute abdominal pain, peripheral neuropathy that's significant, projectile nausea and vomiting, seizures, they need to be treated immediately. So I tend to put them on hemotin. It's also important to point out that people that have porphyria, although they may have only one attack of abdominal pain, they may go on and develop peripheral neuropathy. So with unexplained peripheral neuropathy, porphyria is part of the differential diagnosis. And I see a lot of patients from our neurologists who are working someone up. They worked them up, can't figure out why they have peripheral neuropathy, and they send them to me to look to see if they have porphyria. And I have found people that have acute hepatic porphyria that when I query them about having acute abdominal attacks, swear to God, they've never had one. But nevertheless, they have elevated PPGs in their urine at the time that I see them. Usually mildly so, but they're there. So acute attack is, get rid of the trigger, whatever that may be, alcohol, caloric restrictions. I suspect that we're going to see more porphyria because of the new GLP-1 and SGLT1 inhibitors that are out there for weight loss. People are losing 45, 50 pounds, and they're losing weight because they've lost their appetite. And I'm virtually certain that we will start seeing more and more cases of porphyria because of that. You begin, if they have mild disease, you can be in glucose, either orally or IV. I point out that there's been no randomized studies looking at oral glucose. So I use IV glucose if I use it at all, which is very rarely. And then you start hemotin. The issue with this is once you start hemotin, measuring the porphyrin levels and porphyrin levels in urine may be fraught with error. And the reason for that is that on occasion, the PBGs and porphyrins will go to negative within 24 hours of receiving a dose of hemotin. Oh, something went wrong. So how do you prevent it? Well, you get rid of this, get rid of the triggers. Another option would be to put people on prophylactic hemin once every one or 2 weeks. Or the other thing would be gavoceron, what I'm sure everybody here knows about, which is a messenger INR inhibitor, which is quite successful, I think, in my experience. It's as useful as hemotin is for prevention. It's not of value during an acute attack, although there is some of us that use both gavoceron as well as hemotin together when a person has a breakthrough with gavoceron. So gavoceron is given subcutaneously. It can be associated with renal impairment, particularly in people that start out with renal impairment. There is a thing that can occur once you develop increased liver enzymes, which appear to correct themselves on their own over time. You can develop homocystinemia with it, where you have real high blood homocysteine levels. And there have been cases of severe pancreatitis that have been associated with gavoceron alone or gavoceron with the complication of exceedingly high homocysteine levels. And I should also point out that acute hepatic porphyria itself can cause high homocysteine levels. There's been some manuscripts that have been published claiming that 40% of people that have acute hepatic porphyria have very high homocysteine levels. That's not been my experience, but I have seen high homocysteine levels in some patients. Okay, I'm going to skip that one. This is about hepatic. Hepatic transplants, which may or may not work, but when it does work, it's fairly dramatic. And I have taken people to transplantation when they've had intractable, severe, life-threatening acute hepatic porphyria. They both had AIP, and one got much better, and the other one didn't. Porphyria cutanea tarda. Well, it's one of these chronic cutaneous porphyrias where, due to photosensitivity, you get blistering the skin and the dorsal of your hands, but also in your face, around your ears, sometimes the back of your neck, any place where you're exposed to the sun. There's type 1, which is 80% of the porphyrias, and these are due to deficiencies of the urod enzyme, uroporphyrin decarboxylase. But it's not due to a genetic defect. It's due to a suicide inhibitor that inhibits the enzyme itself. And a very common cause of this is iron supplementation, or sometimes it could be associated with hepatitis C. And this is one of the reasons I think that EPP is now the predominant porphyria that, at least that I see. And that is because hepatitis C is now a curable disease, and hepatitis C is going away. And it was a very, very common cause of PCT. There's type 2, which of course is a familial form, it's genetic. And then there's this very rare hepatic urod gene defect, which is due to an increased degradation of the enzyme itself. This can all be triggered by hemochromatosis. Of course, hemochromatosis is a disease characterized by increased tissue levels of iron. Alcohol can cause it, and my experience is this is actually the most common cause that I see. Hepatitis C can do it. Estrogen therapy can do it. Estrogen therapy and combined oral contraceptions, or for patients who are a little bit older and are getting hormonal replacement therapy. This is a schematic of what this inhibitor looks like. It's called uroporphomethine, and it's a molecule that's very similar in structure to uroporphyrinogen, and therefore it competes for the binding site on the urod molecule. If it binds to uroporphomethine, which has a little bit more avidity for, then urod is not available to decarboxylate uroporphyrinogen. So a characteristic of people that have PCT is you have a predominance of uroporphyrins, and then you have the hepta, hexa, and pentas in decreasing concentrations. Another characteristic of a person that has PCT is the presence of a rarely detected form of a coproporphyrin called isocoproporphyrin, and it's called that because it has a slightly different side chain on it. It is highly water insoluble, so it's found in bile and stool, and it is pathognomonic for the presence of PCT, whether it be acquired or hereditary. So here we go. So this is a patient with PCT. They get these blistering lesions that can be scarring, and their urine can change colors as indicated below. Often measuring the urod enzyme is fraught with error because it's not abnormal to begin with, because it's mostly acquired, and the urod enzyme measurement is a difficult measurement to do in the laboratory and can only be done in red blood cells, and even then it's pretty debatable whether it can be done accurately or not. The activity enzyme would have to be around 20 to 50% in order for it to be associated with the disorder. And of course, you would have to have something that would stimulate ALAS to increase porphyrin precursors, even if you had a defect in the enzyme itself. So the treatment for porphyria cutaneous tarda, well, phlebotomies, I guess we probably all know this already. It's chelation, perhaps. Hydroxychloroquine, 100 milligrams, maybe 200 milligrams twice a week. Treat the hepatitis C if they have it. If that doesn't work, it's possible to plasmapheresis these people. Another, I won't say common cause, but another cause of PCT that's acquired is people that are on dialysis, and that's due to the toxic effect of heavy metals, which inhibits urod. And it's due to the lack of clearance of the uroporphyrin breakdown products during dialysis itself. And in those circumstances, what you have to do is increase the duration and the frequency of dialysis, and check the patient for heavy metal poisoning and remove any heavy metals from the dialysate. And obviously, it would be to avoid iron replacement if it's at all possible, and to stop alcohol and stress. Stress commonly is a trigger for, virtually all the porphyrias. And I've had people that have had terrible PCT because of marital stress, or they've had people in the family that had major accidents and they're under great stress as caregivers. Congenital erythropoietic porphyria is autosomal recessive, defect in Uros enzyme that I've described to you already, blistering. And the key to this is it is so severe that these people can get intractable hemolysis, get these big spleens, and I've already described to you the photomutilation that they get. And these people can be mistaken for having some sort of severe autoimmune hemolytic anemia, and be mistreated for a lengthy period of time because they don't have a lot of photomutilation. And also, as I said earlier, because of this buildup of the uroporphyrins, the heptaporphyrins, the hexacarboxyls, and the pentacarboxyporphyrins, they can look like they have a urod defect, and they can look like PCT when it's very, very mild. And so anybody with PCT has to be evaluated to make sure they don't have mild CEP. Okay. So what's it look like? Here it is. Okay, photosensitivity, 100% of people. That's because of the concentrations of the porphyrins in PCT are, 50 times greater than normal, and 30 and 40 times greater than what you would see in a person that has EPP or PCT. Okay, so these people are highly photosensitive. They get terrible burning in their skin. They develop fragility of their skin. They may blister. They get scarring, get traction of their lips. They scarring of their sclera. They lose their earlobes, their nose, other protuberant organs they may lose. They get hypertrichosis for reasons that I don't really know. They can get hepatosplenomegaly, which is due to the hemolysis that they have, and they can develop a low platelet count, again, due to large platelets, a large spleen that they have. And these pictures show you that they lose bone. Notice the hands, part of the fingers are missing. That's due to involution of the bones itself. And that involution is due to the scarring in the skin that retracts and makes the hands very difficult to use. So you develop severe osteoporosis. The teeth are turned black because of depositions of the porphyrins. Patients lose their enamel. They develop severe cavities. Their teeth begin to rot. Their bones in their maxilla become osteoporotic. They lose their teeth. It's a terrible disease. So treatment for this, well, protection, vitamin D replacement, transfusions when necessary. Sometimes you can use that to suppress the ineffective erythropoiesis that these people get. Plasmapheresis to lower the porphyrin levels acutely, removing the spleen in an attempt to prevent patients developing severe hemolysis, and obviously bone marrow transplantation, since it's an erythropoietic disease. At least we hope that it's curative in most people. There haven't been that many people that have been transplanted to know for sure, be exact about it. There is some evidence from the European literature in pediatric cases that patients that have undergone hepatic transplant without a bone marrow transplant, that in the original liver, they had liver failure because they had infiltration of the liver with isomer 1 uroporphyrins and coproporphyrins. and when they were transplanted with new liver, that the new livers also began to become infiltrated with the porphyrins. So the a liver transplant without a bone marrow transplant seems to me like it's probably relatively contraindicated. So hepatic carcinoma, there's an increased risk with AHP for sure, and with PCT. It's likely due to a direct effect in porphyrins on the liver. Recommendations are now that we begin screening people at age 40 with recurrent liver ultrasounds. I do serum alpha fetoproteins. That's not part of the recommendations, and there's a debate as to whether alpha fetoproteins are actually increased in these patients, but it's what we do, with other patients also. So I don't see any reason not to do it. Sometimes you can make a diagnosis pretty easy in your own little hospital just by looking at the fluorescence of plasma and PCT, and the other porphyrins it's about 620, and VP it's 626, and EPP emits at 634. You can make the diagnosis of EPP by measuring the protoporphyrins in whole blood. In EPP, 85% of them are metal-free. That is to say, there's no zinc or iron in it, and the reason for that is the ferrochelatase enzyme is missing. In XLP, the defect is in gain of function of ALAS2, and because of that, the FEC enzyme is intact. It's overwhelmed by the precursors, and for that reason, metal-free protoporphyrins are less than 85%. You look at stools and fractions, primarily look for HCP, VP, and to confirm a diagnosis of CEP. This is what I do for practically everybody that I see that I think has an acute hepatic porphyria, is get a whole blood sample, primarily looking for evidence of increased protoporphyrins, and to measure HMV-S and urod as indicated in red cells. I get urine ALA and PBG with total porphyrins because you screen for virtually all the acute hepatic porphyrias by that simple step. I often ask for them to be fractionated because I can type the type of porphyria they have, the type of AHP they have based upon what their urine looks like. And also I can make a diagnosis of PCP in most patients. Measure plasma in people that I want to check the fluorescence. That's primarily with VP. Check fecal sample to look for VP, HCP, and to confirm PCT if in doubt. And I measure serum or plasma PBG in people that have renal impairment. Sometimes I'll take a look at whole blood or erythrocyte porphyrins, and you would look at that to, again, to confirm a diagnosis of CEP, EPP, and sometimes AHP. And PCT, you have an increased porphyrins, but they're very, very small increases compared to EPP, and that helps differentiate between the two of them. What about enzymatic testing? I do it in everybody because I want to build the library up. But the problem with doing it is people get focused on it. They have a patient finds out they have a defect and they start thinking they have acute porphyria when they really don't. We refer to that as latent porphyria. And indeed, if you have an HMVS defect, but without symptoms, it's possible you could have an attack at some time in the future should ALAS1 be stimulated, but most people don't. And for urod deficiency, I've done this for many years. I've seen 2 people with urod deficiency that's hereditary. All the rest have been acquired. And it's important to point out that a defect in HMBS or PBGD is both in the hepatocytes and red cells. We can only practically measure red cells readily, so it's pretty hard to measure in the liver, and it's not reliable. So although about 50% of people have red cell involvement, 50% of people don't. So sometimes these measuring these enzymes are of no value, and that has to be taken into consideration. What else about DNA testing? Remember, it's 1% penetrance for acute hepatic porphyria. For EPP, the penetrance is 50 to 100%, so it's much more useful in that setting. It's really used primarily to detect carriers in the family and to counsel people and to build this library of what mutations are associated with these disorders. So this is a summary. I'm not going to go through that. I'm done.
Well, thank you so much, Dr. Smith. I know that's a lot for everyone to take in, but I know that I learned so much. And I think one of the best things that most of us can take away from that is it is very difficult. Not everyone has the same symptoms when they're presenting. So it's difficult. And the way you explained that uroporphyrinogen molecule being, inflexible, that was neat. I'd never heard that before. So thank you so much. I know that we've got a lot of questions here. And some of them you answered in your let's see, hold on a second, in your presentation. Hold on a second. All right. All righty here. So let's just kind of start. I know that the first question, just to kind of go back to that, is do all patients with porphyria have dark purple or red urine or any change in urine in general, as well as abdominal pain? And I know you went over that most people do, you don't have to have that. I don't think there's anything to add to that. Do you?
No, I don't think so. I think it's all in the timing of looking at the urine and realizing that it does take time for the urine to change colors. So,
Okay.
so you can't get a urine sample and set it on a desk and expect it to change within 5 minutes. It takes a while. It also depends the type of light you're exposed to.
Okay.
And a lot of the new fluorescent lights have eliminated the blue range in them. So you have to have a short range in order to get the color change to take place.
Okay. Okay, great. Another question is, the second question is, a patient is interested in hearing about the long-term effects on the liver, having some elevated ALP, ALT, and AST during attacks and heme infusion. So does hematine cause abnormal platelet levels?
The answer is that acute hepatic porphyria can cause liver enzymes to be elevated during an acute attack, and in fact, they've been chronically elevated. There is evidence. It is based upon population, so it's not from randomized clinical trials, which is the gold standard for any scientific information about medicine. But it's a large population study that was done in Scandinavia, looking at liver functions and the fate of the liver over a long period of time. And it's very interesting. What they showed was that in patients that had marked elevations in porphobilinogens repeatedly, or had porphobilinogens that were elevated for a prolonged period of time, they were referred to as chronic hypersecretors. This is perhaps 30% of people that have acute hepatic porphyria, although most of them that have been identified are AHP patients. That if you have that, it looks like you have a risk of developing deteriorating liver function over time and that same population may be the population that has the major predisposition to developing hepatocellular carcinoma over, 20 years.
Okay.
So that's that part of it. The part about the, can your urines be normal and stuff like that? I get this question all the time, and I get this question all the time because I see a lot of patients that come to me who have been on the internet, and they've read things about porphyria, and they're upset because they have some some disorder of some sort, and some of the symptoms share the symptoms of a person that has porphyria, so they come absolutely totally convinced they have porphyria. This is one of the banes of Google, because people go to Dr. Google when they ought to go to their doctor, and so I have lots of people come to me complaining about having abdominal pain. I have lots of people that tell me they were in the hospital, and oh, by the way, they got hematine on the hospital because the doctor didn't know what else to do, and they got better, and they have to have porphyria. Absolutely untrue. It is almost impossible to have a normal urine analysis during the onset of an attack of acute porphyria. I've never seen a case of it. Okay. And furthermore, your porphyrobilinogen levels and ALA levels are highest during the acute attack. And this is why there's this thing out there in the medical literature as well as the lay literature saying, you got to get these samples while a person's in pain.
Sure.
That's not true. That's not true. But it does make sense because your levels are highest then.
Sure.
Okay. But it does take a while for your levels to drop down if you're not being treated with hematine. So they stay up for weeks, and in the case of AIP, perhaps years. So it's literally it doesn't make any sense that a person would have abnormal urine values and have an acute attack.
Okay. Thank you. No, that's great. Here's a question. Can you donate blood at a blood bank if you have PCT?
Yeah, as long as you don't have an attack.
Okay.
So, like I said, PCT is an acquired phenomenon for most people. And when you donate blood, you're donating primarily red blood cells. There are some white cells there. There are some lymphocytes. But the genetic defect is in the DNA, which is in the nucleus of the cell. Red blood cells don't have a nucleus. Okay? So you're donating cells that cannot transmit the disease to anybody, and you couldn't transmit it anyways. Even if you had nuclear cells, a lot of cells there that had nuclei, you wouldn't transmit the disease anyways. So
okay. Yeah, some people are saying that the blood banks did refuse them. So I guess patients that have been told that, you can tell them that Dr. Smith said that you can donate blood.
well, that's their choice, right? I mean,
Sure.
so if you're running a blood bank, I mean, you can say the same thing about people that have polycythemia vera. I'm old enough that I remember when we used to phlebotomize people with polycythemia vera, we gave it to the blood bank.
Wow.
Now, in this modern day and age, the blood bank is very, very, very careful of who they will take donations from.
Sure.
So and that's up to them as to whether they will accept or not. But there's no true contraindication to it.
Okay. All right. Thank you. Are there any treatments or supplements or anything that can repair liver damage if you do have long-term damage from having porphyria? Is there anything that you can do to try to help repair that?
No, none that's ever been described. Yeah, I would add to that that people with porphyria do have a risk of developing steatohepatitis, that is liver infiltration with fat. Now that predisposition isn't due to porphyria; it's due to the diet in the United States and the presence of diabetes. Liver infiltration with fat is epidemic in the United States right now because obesity is epidemic.
Sure.
And there are some things that can be done to reverse fatty liver in that setting, but it would have to be approached very carefully because the data that's presently available is that would be the SGPT1 or the GLP-1 agonists that are used for weight loss. And of course, weight loss might stimulate acute hepatic porphyria. So there have to be something to be done under the direction of a physician. There's no way that we know of to remove porphyrins from the liver once it's there.
Okay. All right. Here's another question. How does HMBS related leukoencephalopathy variant affect individuals with the autosomal acute intermittent porphyria, such as symptoms for an attack, or how is this addressed by or with neurologists? If you know that. I know you're not a neurologist.
Yeah, that's a hard one because other people have asked me the same thing. And, when I've gone through the literature, at least what I can glean from the literature is that, if you're a carrier with an HMBS mutation that's associated with leukoencephalopathy, if you're a carrier only, you have no risk. Okay, you have to have 2 genes to have the disease.
Okay.
Now, the other thing is HMBS neurological disorders. Most of them occur in childhood. So if you're an adult, your risk is probably very, very small. There is a presentation in adulthood, but only in homozygous patients. So I think it may be for a person's heterozygous at any rate irrelevant.
Perfect. Okay, thank you. There's a question, and I think you answered this. If someone is not symptomatic to be able to do the biochemical testing that you explained, is the best way to get diagnosed to do genetic testing? Is that what you would suggest?
Say that again.
For patients that are not in an attack, or for family members that are asymptomatic, if they don't have the biochemical testing, is the best way for them to get diagnosed to just doing that DNA testing?
No.
No.
The best way to be diagnosed is by biochemical diagnosis at the time you have an attack. Now, the reason for that is, again, is the penetrance of the mutation. Now, acute hepatic porphyria, remember the penetrance is 1%. With CEP, it's slightly higher than that. I think it's 20%. With EP, it's 50 to 100%. So if you have a family member that has EPP, well, yeah, if you're concerned about it, it makes sense to take a look and see whether there is a genetic defect in a gene that codes for the FEC enzyme, the ferrochelatase enzyme, with the understanding that there are non-FEC mutations that can also cause EPP, and they are rare. Okay. So if you have AHP, acute hepatic porphyria, since the penetrance is 1%, even if you had a genetic abnormality, the chances of you having AHP is close to 0. So I wouldn't bother to look for it if it's a personal issue to you. If it's an issue about, you're going to get married, or you're sexually active and you're planning on having children, slightly different story. If both you and your spouse or your partner carry the gene, then you're going to want to know that, because you're placing your child at risk.
Okay.
You're going to want to know that in advance.
Okay, great. If you have porphyria and a fatty liver, are you more susceptible to frequent attacks?
Unknown.
Okay. All righty. Let's see. And let's see here. This is something that we get asked a lot too, especially with the genetic testing that's available, trying to counsel and figure out how rare or common is it for porphyria patients with a known mutation to actually have more than one type of mutation in different porphyria genes or different types?
Oh, I don't know what the frequency of that is, but it's very common for them to have variants of unknown significance throughout the genome. I described that earlier in my
Sure.
talk. It's very, very common. This is something that I, I deal with every day. Take my
Yeah,
word for it.
I know.
And it's because of the fact that medicine is going more and more doing genetic analysis. So I do a lot of panels on people for leukemia and other hematological disorders. Most of these panels have 50 or 60 different genes that we look at. Some of them are 1,000 genes, and it would be very unusual if I did not get a report back saying that there was a mutation of unknown significance. So now, how often you would see a person that has a mutation of for example, HMBS gene that is pathologic, and then another mutation of HMBS gene that is of unknown significance, I don't know. I can't tell you that, because it depends on the panel, how big of a
Sure.
panel you do.
Okay. And then Yvonne was asking in the chat, which is just related to the last question, how is, I know you explained this in your presentation, but just maybe in more layman's term, how is penetrance determined? Like about AHP is 1% and EPP can be 50 to 100%.
So determined by comparing the frequency of a known pathological variant that you detect by a laboratory test looking at the genome, and the frequency of the presentation of the disease within a fixed population.
Okay.
All right. So and we know, based upon studies of the general population, that porphyria is a really relatively rare disease, and we know by the genomic studies that we're presently doing that it's a very common mutation that we see.
Yeah.
So that's how you calculate the penetrance. Now that calculates the penetrance will likely change over time, and my bet is that the penetrance will be even lower. That's my bet.
Okay.
And because I think what we're going to find is more and more variants in the HMBS and the CPOX and the PPOX enzyme genes for those enzymes that are going to be of unknown significance and not associated with the disease itself.
Okay.
That's what I think is going to happen over time.
That's interesting. Here's a good question. How or why does AIP affect kidney function? Are long-term effects on the kidney, if there are any, is it relying on the number of attacks that affect the organs, or is it just having the disease in general, how it affects the kidney?
Boy, I don't know the answer to that. The pathology of the renal involvement is due to deposition of the uroporphyrins in renal cells, and the glomeruli and the renal tubules. That we know. Now, whether there is an association with prolonged high levels or very, very high levels during the acute attack is unclear. But in that population study I was talking about in Scandinavia, where they looked at the frequency of hepatocellular carcinoma, they did comment upon the frequency of chronic renal disease, but these weren't based upon biopsies; they were based upon the course of the patient, and there was an increase frequency of renal impairment in people that had porphyria with increased porphyrin levels.
Okay.
Now, without there's lots of things that cause renal impairment.
Sure.
So within the population of people that have porphyria, that increase in renal impairment could have been due to age, or it could have been due to some medication they were taking, or they had high blood pressure. That you can't ferret out from that information.
All right. Now, someone is asking, can scarring occur without injury to the skin with porphyria and not have cutaneous sensitivity? I think that's a pretty quick
That's a
one.
good question. Not that I know of. You know, people that have CEP commonly get, before they get fragility of the skin, they tend to get thickening of the skin. You'll see some of these people and they'll look like they have a major suntan,
Okay.
you know, and that's due to thickening of the skin. And you can have people that have PCT who have, you know, scarring of the skin from previous attacks of these bullous lesions that they get, and that causes thickening in that area. So, you know, I suppose you can get that secondary to blistering where you don't get any blisters after that, but the skin's thickened. But other than that, I don't think so.
Okay. And Juan is asking how or if the porphyrins affect the vascular system in any way.
Well, they affect the vascular system for sure. Okay, now exactly how can I answer this? I mean, porphyrins are carried in plasma in the serum. So porphyrins, obviously, you know, the endothelial cells, which are the lining of the vascular cells, are exposed to porphyrins. I don't know that anybody's ever looked to see whether that actually causes damage directly to the blood vessel wall. I don't think I know the answer to that directly.
Okay.
We do know that porphyrins are deposited in other tissues. There's clear evidence that in people that have EPP, as an example, that have high protoporphyrin, metal-free porphyrin levels, that protoporphyrins occur in both the liver and in the erythroid system. And if you block the release, at least in mouse models, if you block the release of protoporphyrins from the liver, that you don't get other tissue damage from it. Okay.
Mhm.
And you get worsening liver disease with it, which is very interesting because it's counterintuitive.
Yeah.
But you can block the transporter for protoporphyrin and actually cure a mouse.
Wow.
Now, whether that is true in a human or not, we just don't know. But if you reduce the protoporphyrins that are in plasma, then you're going to reduce the protoporphyrins which the vessel wall is exposed to. And we also know that in acute hepatic porphyria, during an acute attack, people often have either hypertension or they have volatility in their blood pressure, or they have marked hypotension. So now that's due to the porphyrin precursors, ALA and PBG, most likely.
Okay.
So it wouldn't necessarily be due to porphyrins, but it's part of the presentation of people that have acute hepatic porphyria. So there's definitely an effect. But whether there's actual damage to the cells or not, I don't know.
Okay. Now this is something that we hear a lot, and someone sent in it. As far as I know, you went over the treatments for acute attacks of for AHP. Are there any treatments for the permanent nerve damage and the chronic pain? Did the treatments help for chronic pain as well? And is there any treatment for permanent nerve damage?
Well, there's no
Permanent, I would doubt it, but that's the
There's no-
question.
there's no treatment specific for porphyria, okay,
Okay.
in that setting. But you know, the treatment for chronic neuropathy is the things that we use for chronic neuropathy from anything else. You know, it's basically things that sedate the nerve endings. You know, gabapentin, those kinds of tricyclic antidepressants, things like that, that slow nerve conduction, and therefore reduce the ability of the pain fiber to emanate the signal that you're having pain. But it's nothing specific for porphyria. Once the damage is there, as far as I know, it's there.
Sure. Okay. So I know you went over a lot of the common presentations or, symptoms. Someone is asking if they have, we hear a lot with diarrhea, constipation, gastroparesis, things like that. What about urinary problems with blockage? Someone said that they have problems with urinary blockage that have worsened over time and requiring repeated hospitalizations with urology. And is that possibly related to porphyria?
Well, it can be. I mean, I doubt it. I mean, but it can be. Porphyria can cause any kind of peripheral or autonomic neuropathy. Autonomic neuropathy refers to those organs in your body that are controlled by the vagus nerve, and so any of our visceral organs that sort of work automatically, that you don't have to think, to get them to work, can be altered by the presence of porphyria and peripheral neuropathy. So now gastroparesis, as an example, is an example of an autonomic neuropathy, and that has been well described in people that have acute hepatic porphyria. People that have ileus, chronic ileus, where your bowel just simply can't contract normally,
Sure.
That's an autonomic neuropathy that occurs with porphyria. So I think it's possible. Yeah, but there are many other things that do it.
Sure. Okay. No, that's great. That's good to know. So someone was asking, they have several, ongoing attacks with hospitalizations, and this is something we hear a lot as well. How do you know when is it time to go to the emergency room, or to just, if you are a diagnosed patient and you have if you're going to go get treatment, how do you know when it's time to go to the emergency room? That's something that we would never answer, but since I'll put you on the spot.
I'm not sure I can either. I mean, I think if you're a person that you have porphyria, you've had multiple attacks, then I think you probably know that already just by your previous courses. But
Sure.
clearly, if you're having severe abdominal pain that you just can't function, or you have an association with it with nausea and vomiting, and you're feeling dehydrated, or you're feeling lightheaded, that's a reason to go. I mean, so even if you didn't have an attack of porphyria under those circumstances, you should go to the emergency room.
Okay.
So,
Right.
the other thing is if you have pain that's can't be controlled by the normal pain medicines that you have around the house, non-narcotic pain medicines, that's definitely a reason to go to the emergency room.
Great. Okay. So there's a doctor on the call, and he says he has a patient on dialysis, renal dialysis, and would you suggest, if that was your patient, to going on Givlari?
Yeah, thank you for your email, by the way. We came on, and I was thinking about this. I personally have not had experience with a person who has acute hepatic porphyria that's been on dialysis. I've certainly had experience with people that have an acquired porphyria that's on dialysis.
Okay.
And the patient that's being described, if I remember correctly, was also being treated with Hematin and dialysis, and was getting some sort of relief, but not total. To the best of my knowledge, there's nothing published about the use of givosiran in the presence of hemodialysis.
Okay.
However, givosiran has a relatively short plasma half-life. It's only 6 hours. And I think if you timed it right, I don't see why there would be a contraindication to giving givosiran in this setting. After all, you are dealing with a patient that already has renal failure and is on dialysis. So the issue isn't increased renal toxicity from givosiran. The issue is there a way to reduce the amount of porphyrobilinogen LAL that's being produced? And it makes sense that the combination of putting this patient on Givlari plus putting them on a hemodialysis would be effective.
Right.
Now, I was at a research conference a year ago or so where something similar to this was discussed about placing people on the combination of Givlari as well as Hematin, particularly when they have breakthrough, or if they have a history of severe AHP. And the rationale behind that was that you're exposing the person to different mechanisms to decrease PBG production and ALA production. And this would be a similar setting where the difference is, of course, you're trying to reduce production while you're trying to remove the excessive PBG and ALA that they have. And that makes very good sense to me to do that. And particularly it makes sense if you had the person on Hematin and you were dialyzing them at the same time and you saw an advantage to that. So now, as I said in my talk, people with acute hepatic porphyria, at least genetic form of it, do have a tendency to develop high homocysteine levels on their own. There was the one manuscript, like I said, at least I think I said, reported, about 40% incidence of high homocysteine levels. I haven't seen that myself, but it's been reported in the medical literature, and it's been reported by multiple people that you develop high homocysteine levels. And so high homocysteine levels in a person with renal failure is kind of routine. So one of the things you'd have to be careful about is giving a permanent. The other thing is Givlari induces high homocysteine levels in some individuals. So one of the things you'd have to be careful about if you give a person Givlari in these circumstances is you'd have to be sure that you're not predisposing them to excessive homocysteine levels, because that can cause acute pancreatitis. But if they're on dialysis, the homocysteine will be dialyzed. So
Perfect.
I don't see a downside to it.
All right.
I have no personal experience with it.
Okay. Someone has PCT and they said they were recommended by one expert to take hydroxychloroquine on an ongoing basis to keep the symptoms at acceptable levels. Then they were told by another doctor that they stopped taking this treatment because the side effects, and they just would like to know, like, how do they kind of look at, can you elaborate on that, the treatment versus the side effects?
Sure. So first of all, hydroxychloroquine is a very effective therapy for PCT. It is as effective as phlebotomy is. Now, it may take a little bit longer for hydroxychloroquine to work. If I remember the data correctly, and I haven't looked at it for a while, so I can be wrong about this, but I think the time to remission with hydroxychloroquine when compared to phlebotomies is maybe 2 or 3 weeks longer, which in my view is not an important issue.
Okay.
Of course, I don't have the disease either, so but hydroxychloroquine can do a couple of things. It's a sulfa drug, so sulfa drugs can cause allergies. Sulfa drugs can be associated with hemolysis in certain people that have G6PD, enzymatic defects in the red cell. I don't want to go into too much detail here, but
Sure.
there are enzymatic defects in red blood cells that predispose them to being destroyed in the vascular system, and hydroxychloroquine can make that worse. Hydroxychloroquine can be associated with renal impairment, mechanism unknown, but the creatinine goes up, the creatinine clearance goes down for some patients. The one that we get most concerned about is long-term hydroxychloroquine can cause a retinopathy. That is, can cause an abnormality in the lining of the eye, which detects light and color. And so anybody on hydroxychloroquine needs to have a baseline scan of their eyeballs done by a ophthalmologist. When I say scan, for the a slit lamp examination, and then they need to have it done periodically. I generally do it annually for people that are on hydroxychloroquine.
Okay.
And I always check their liver function, their kidney functions to make sure they're doing okay. So it's a balance between those side effects, which do occur, and the value of hydroxychloroquine. That being said, hydroxychloroquine, in my experience, has been a very, very safe drug. I use it for lots of different things. It's also used to treat systemic lupus. I use it in people that have a lupus anticoagulant. I use it as an anticoagulant. I have many people that are on long-term hydroxychloroquine, and I actually have not seen any side effects to it. So I think it's a pretty safe drug to use. So now there is no evidence that the combination of hydroxychloroquine plus phlebotomy is indicated. Although same rationale, I mean, there's no evidence because no one's ever looked. Okay.
Sure.
But if I had somebody that had PCT and they were on hydroxychloroquine and they weren't being controlled, then what I would do is I would move to phlebotomies. If phlebotomies didn't do it, then I do both as a trial. And often people that have PCT who are unresponsive to therapy are people that either have hepatitis C and they don't know it and hasn't been treated, or I have a patient that I see long distance who has PCT, who is in a high stress job. It's in the medical field, is under runs a nursing unit and stuff like that under very high stress, and it doesn't seem to make any difference what you do. She gets these lesions on her hands and face when she's under stress. And I have another patient who is a professional. If I remember, she's a real estate agent. That's a high pressure job to begin with.
Sure.
But her son had a major injury, and she's now the caregiver for a person that's paralyzed, and she's under horrendous stress, personal stress, and every time she's in a stressful situation, she gets this.
Wow.
So there are some things that that the trigger is just there, and when the trigger occurs, you get the attack.
Sure. We're gonna do two more because we're putting you on the firing squad here a little bit. For those who have acute porphyrias, and this particular patient says they have HCP, and they do get while they're being
Have what? HCP?
HCP.
Yeah, okay.
Are there any, and I guess you could address it for any of these, are there any of the porphyrias, the AHP and PCT or CEP that we're discussing today, are there any other diseases that should be tested on a preventative basis? Like you just said, the scan for the retina, you recommend that once a year. Are there any other diseases that porphyria patients should be looking
Yeah.
to
Absolutely.
preventatively?
Yeah. I mean, your liver function should be looked at, renal function should be looked at for sure. The other thing is that there are other diseases that can look like, as I said at the introduction of my talk, there are other things that can look like acute hepatic porphyria.
Sure.
As an example, I inherited a patient from another practitioner that had been on Hematin for, I think it was 4 years. And when I went back through his records and everything, he had some elevations in his urine porphyrins, and his porphobilinogen was barely increased. And it turned out that he had hemochromatosis.
Wow.
I took him off Hematin. Didn't make any difference whether he was on it or not, which is, but there are other diseases that can look like you have AHP. And so you have to look for those things. And for acute hepatic porphyria, lead toxicity is a biggie. Okay, I mean, depending on where you live and how old the city is, and what kind of paint you have in your walls and stuff like that.
Sure.
But people that have lead intoxication can develop very high porphobilinogen levels, very high porphyrin levels. They look very much like they have, porphyria, and it's acquired, and the treatment is to get rid of the lead, stop
Wow.
the exposure and chelate the patients, get rid of the lead. There's this disease called primary tyrosinemia, which can do exactly the same thing. So those things ought to be looked at, when you see a person that has porphyria, if it's appropriate. Now, those two things I just described present as if you have ALAD. So in those patients, you would have high porphyrin levels, especially copers and uroporphyrins. Total porphyrins would be increased. Your ALA would be very increased, and your porphobilinogen would be either normal or barely increased, and that's where the art of medicine comes in. And this is probably the biggest issue that I see with other practitioners that see porphyria patients, and that is that it's a relatively rare disease, and not a lot of docs see a lot of the disease. So
Sure.
so the biggest issue is how you interpret the laboratory results and how you make the diagnosis. And the biggest issue I see is a misdiagnosis of porphyria. I see lots of patients are sent to me or come on their own, or Google, patients that make their own diagnosis and talk to Aunt Fanny down the street or their next door neighbor and decide they have porphyria. But there's this other population of patients that come to me because, a physician or a physician assistant thought about porphyria, which is the right thing to do.
Yeah. That's what we want them to do, right?
Exactly. And they get the results, and they can't interpret them, because because some of these interpretation of the results can be very subtle. And that's not a criticism. That's an advantage, but I do get these patients that come in and they've been told they have porphyria, and when I evaluate them, they don't really have it.
Okay. All right. This is a very interesting question. Someone's asking about the psychiatric symptoms that come with acute hepatic porphyria. Will they resolve with treatment of panhematin, and also do regular, if they put a little bit of history here, if they've been in the hospital and they've been trying to be putting them on psychiatric drugs. Obviously with acute porphyria, we're always looking at the safety of the drug list that we have on the American Porphyria Foundation has safe and unsafe drug list on our website to check. But so do they need those drugs as well? Maybe for, does, and the panhematin treatment, or, what do they do with that?
Well, there's a couple issues there. One is that it is very common for people that have an acute event to have psychological changes with it. Brain fog, like I described it, in my experience, that's the most common thing. But you can have acute psychiatric changes. You can have delusions, hallucinations, seizures, that sort of thing that tend to go away when the acute episode is over with. There's another side of that too, and the other side to it that I mentioned earlier is you can get permanent damage. That seems to be related to the severity of your acute attack, the number of acute attacks, and whether you have chronic elevations in porphyrobilinogens and or ALA. It remains debatable whether the major toxic insult is due to ALA or porphyrobilinogen. In humans, ALA mimics in structure gamma-aminobutyric acid, which is a chemical that's necessary for nerves to work normally.
Mhm.
So assume ALA is the major thing, but there are mouse studies where mice have been given PBG, and they have neurological deficits afterwards. So PBG probably also contributes, and so the other thing that contributes is the frustration of having porphyria and having recurrent episodes and going to the ER over and over again, having multiple surgeries, going to multiple doctors and nurses and people that haven't thought about it, haven't made the diagnosis, don't know what to look for, and remember the disease from when they were in training, but never saw it. This is kind of routine stuff. And that leads to, and that leads to patients coming in and they are angry, they're frustrated, they're desperate, and they frequently have associated with that. I don't want to say psychiatric damage, that's not the right word, but they have psychiatric changes because of the frustration that they have.
Okay.
Doc, please believe me, this is what I have.
Right.
And often I can't resolve that because many of these people have convinced themselves they have porphyria when they don't. And when they're told they don't have it, they still have the symptoms,
Sure.
and I don't know what's causing them,
Right.
So there's a psychiatric component to this that can be a major event. And so now in terms of, the drugs to use to control depression and anxiety and, that sort of thing, I always refer to multiple websites. The main website I refer to is the AHP website for, safe drugs and unsafe drugs. I also go to websites in Europe. They are slightly different. I think a lot of the drugs that are on these, they're declared unsafe, are probably safe. They're based upon largely on patient reports, which are based upon temporal relationships, but I don't know because they might be right. So if the website says they're unsafe, I make the assumption they're unsafe, just to be conservative for the patient. But that doesn't mean that that particular drug is absolutely contraindicated if you need it for some other reason. That's where the art of medicine comes in.
There you go.
Okay? And so I made a special effort about 7 years ago to try to find out exactly what drugs really were proven to be unsafe in people that have acute hepatic porphyria.
Okay.
I could come up with maybe 7 or 8 drugs. I can't remember now. And the rest of them, I don't know. But if somebody reports it to me that it made them sick, I'm not going to give them to them again unless I absolutely have to.
Sure.
So now the other thing is I get phone calls all the time from other physicians and PAs and people like that about what drug is safe for people that have EPP or PCT or something like that, and really all this big long drug list of unsafe drugs doesn't apply to non-hepatic porphyrias.
Sure.
Okay. Now there may be an issue with taking oral iron supplement with PCT. That may be because iron stimulates this suicide inhibitor. But most of the stuff that has been reported with that has been with IV iron therapy.
Okay.
So I don't even know whether that's true or not. But I tell people that have PCT not to take iron.
Sure.
Just as a matter of safety.
Okay. Just one more question. Are you okay with one more? We, a lot of people are asking about pain. And we got a couple questions about each of these. What is typically given to patients, in an acute attack? Maybe when they're in the hospital for pain, and also, do you have anything to say? We have a patient that, feels that there's been racial inequity as far as getting pain medications and being treated differently. Those are the two last questions that I'm gonna ask you.
Well, so hospitalization with pain from porphyria almost demands that a patient receive a narcotic. Most of us use morphine because there's lots of experience with it,
Mhm.
with generally good results. And then, downstep it to something less toxic as soon as you can, obviously. In terms of racial disparity, I think there's racial disparity in medicine in general, and that's not a criticism of medicine. I used to run a cancer center at one time, and I made a very, very special effort I did everything I could to get minorities to come in to be screened for malignancy and stuff like that. And it's many minority groups are impossible to reach because of language barriers
Mhm.
and because of trust. And I think particularly, I'm editorializing now, but
Sure.
I think particularly in the Black community, there is a distrust of physicians and nurses of a different race. I think if you look at, for an example, the number of African Americans that are screened for something simple like prostate cancer or colorectal cancer is markedly less than that in Caucasians or East Asians in the United States. But it is not because people haven't reached out to them, offered them the opportunities. When you actually look at the root cause of it, it is that they do not come to participate. And why do they not come to participate? Well, it's because of the Tuskegee experiment, in which Black men who were exposed to syphilis were purposely not treated with antibiotics so that the natural history of the disease could be studied.
Wow.
And that happened in the 1930s and 40s. And I might add, that project was designed and ran by a person here at the University of Pittsburgh.
Wow.
And
Didn't know that.
that is an absolute, complete, total tragedy and should have never happened. So I think there is this natural distrust. The National Cancer Institute has made a special effort. It has mandated that every time we do a study in malignancy, that we are mandated to have, at least 10% of the participants be of the African American minority group, and in general, we achieve perhaps 2 to 3%.
Wow.
And that's with people out there lecturing things on TV. When I ran that cancer program, I had people going, in the Black community, the center of politics and discussion is the barbershop or the hair salon. And I had people going out, to all the Black barbershops in the 50-mile radius,
Sure.
trying to get them to come in to be screened for colorectal cancer and prostate cancer. And, I went to all the churches, gave talks at all the churches and stuff. And, some came, but not many.
Sure.
So I think that these racial disparity issues in medicine are absolutely real.
Sure.
And I think the other thing is, for some of the porphyria, especially those that have cutaneous changes with them, there's another issue, and that is dark-skinned people can have EPP, they can have CEP,
Sure.
and they don't necessarily have the same symptoms that Caucasians do because they have some natural self-protection from sunlight.
Mhm.
And so, that happens.
Yeah. Okay. Well, no, thank you for explaining that. And if someone is has a diagnosis and they are in the hospital in the emergency room and they're not getting their pain treated, do you have any suggestions for them to ask the doctor, how to help with getting their pain treated? Is there, because sometimes when you're not feeling good, this person is saying that they just feel like they're not being listened to. Is there anything that they can do?
Yeah, that happens. My suggestion would just be insistent. And if you have porphyria and the person that's taking care of you is, some hospitalist or somebody that you don't know, it's a rare disease, and people think they know about it when they don't really know a whole lot about it. And
Sure.
I would point out that you have porphyria and please get me somebody that knows something about the disease.
Yeah, and I would add too that with the APF, we have a doctor packet that can be we can share with patients and doctors to give them kind of a quick verse on that to the proper, it's been prepared by experts like you, which tests to do, how to treat and everything like that. So that's always available for people to email us at general@porphyriafoundation.org, or just go to porphyriafoundation.org and just give us a call. We're always happy to help with that. But Dr. Smith, thank you for taking so much time today. I think you've got a lot of thank yous, a lot of appreciation. I know that we're very grateful for you to be on here today and taking so much time. And we hopefully will have you again. I know you're always requested. So thanks for being here today.
Okay, thank you very much. Bye.
Bye-bye. The next thing we're gonna do here is I'm gonna show a video from a patient. She's on the American Porphyria Foundation Member Advisory Board. Her name is Claire Richmond. She has acute intermittent porphyria, and she is a patient. She's a writer and she's also an advocate. She she just was writing in Porphyria News. There's her column is called "A Thousand Flaming Swords," which is something that APF founder Desiree Lyons said many years ago, that the pain of porphyria feels like the burning pain of 1,000 flaming swords. So that's if you guys check Claire's articles out there. But I'm going to show you her video. So get that on right now. I know you're going to enjoy it. Oops, second. Here she goes.
Hi, everyone. I'm Claire Richmond. Some of you may know me from my column on porphyrianews.com. I write about living with a complex, rare, and invisible illness. I myself have acute intermittent porphyria, or AIP, and that comes with frequent, severe acute attacks and chronic symptoms. Before I share more about me, I want to tell you a story. So picture this. A woman and her partner go to the doctor. And then she begins to cry. Without much of a reaction, the doctor pulls her partner aside and says, "I can't find anything wrong with her. Clearly, she's losing it." Now, I have a question for all of you. As you were imagining this scenario, what decade were you in? The 1870s, when troubled women were sent away to asylums? Or how about present day? How many of you were told there was nothing abnormal going on in your body and that all of your symptoms were in your head? Or that your seizures and paralysis were due to extreme anxiety? Before I was diagnosed with AIP, my intestinal tract was paralyzed and I rapidly lost weight because I could neither eat or drink. And I was diagnosed with an eating disorder. Another time, I was in the hospital for 4 months with extreme pain, and they diagnosed me with borderline personality disorder. Sadly, The medical system just isn't made for complex rare disease. It's really good at fixing things that are broken and getting people over humps. But there are some of us who have to live on the humps. And where does that leave us? Medical professionals will likely go their entire careers without ever coming across a case of porphyria. So how do they even know when they encounter it? I wish my story was unique, but sadly, it will be familiar to many of you who have or love someone who has acute porphyria. I went 19 years without a diagnosis. I was misdiagnosed with many conditions and tested for many more. As a community, we tend to dwell on our diagnosis journey because it takes an average of 15 years to get diagnosed, because biochemical tests can be administered incorrectly by well-meaning physicians, and our symptoms are vague and often represent numerous other diseases. Too often we're gaslit by medical professionals and traumatized from ER visits and prolonged hospitalizations that result in no answers. So today, instead, I want to talk about how I've learned to accept my body in all of its pain. I'm in an attack right now. Surprised? I didn't think so. I just got back from the infusion center, actually. Porphyria pain is largely invisible, and a little makeup can go a long way. We all learn to mask with this disease. Living with tremendous chronic and acute pain becomes our baseline, our sense of normality. And if we didn't get out of bed every time we felt pain, we'd just never get out of bed. I don't know about you, but I can push through a lot of pain. It's the nausea and the fatigue that can really get to me. So today I want to tell you 3 super important lessons I've learned in making peace with my porphyria. And I hope that you can find some helpful tidbits within. 1, it is okay to question your doctors. In fact, a recent survey showed that rare disease patients seek out physicians who will collaborate with them for their complex care. This isn't a one doctor only type disease. Most of us go to many other specialists to manage our symptoms. And when there aren't enough patients to know what medications are truly safe or what alternative treatments could be beneficial for symptoms, it's crucial to be open to trying different things. Some will work better than others, and experimentation is scary. I get that. Finding doctors with the time to get curious is also not easy. The US healthcare delivery system just isn't set up for this sort of doctor-patient relationship. I have direct emails and cell phone numbers for several of my providers, and some of you who've been living with this disease for a while can probably also show me your collection of contact information for your doctors. When living with a rare disease, it's crucial to have a point person doctor who manages our local care and is able to stand up for us in sticky situations like being questioned about our diagnosis in emergency rooms when we're in crisis. Mine is my hematologist, and we have a trusting relationship, but it's taken years to build. I average 5, sometimes 6 doctor appointments a week, primarily with providers that I have found through other friends with rare and chronic illness in the area. And I need to be able to ask my providers questions and have candid conversations about what's been helpful for other patients around the world that I talk to who live with acute porphyria. We learn so much more from others in our rare disease community than published research, especially on the day-to-day stuff. Okay, lesson 2. No one will tell you to grieve. There's collective grief in our community over lost time, missed vacations, and life milestones that were somehow limited or neglected because of our body's needs. We watch our more able-bodied friends and peers experience them all. And there's no fast or easy way to grieve, and every day it can look different. The mental processing may seem crushing, but it's absolutely necessary to move forward. I finally realized that when hard feelings roll in, it actually hurts more to hold them in than it does to let myself feel them. I can't describe how difficult that was at first, but all of my feelings were and are valid, and all of yours are too. Eventually, I learned to meditate, and I found a really great therapist and a local support group that's free. Things did not change. My symptoms were still as frequent and severe as they always were, but things were just easier to accept, and I had some support and healthier coping mechanisms. Okay, the third and last lesson is that the rare disease industry is focused on finding cures and treatment drugs, but I wish that quality of life was more prioritized, because a cure isn't going to help me make my coffee date tomorrow morning. Perhaps a study about more effective approaches to insomnia or pain would. My body is doing nothing wrong. I was genetically programmed to inefficiently produce heme. So it really doesn't help me to feel shame about that. But when you go undiagnosed for so long and grow accustomed to managing these black holes of pain, our bodies become really scary places to just sit with. And we lose trust in them. We disassociate to survive. Unpopular opinion, perhaps, but a few years ago, what really helped me was realizing that with AIP, my pain is inevitable, but that I can choose if I want to suffer. Suffering is a choice. If you are undiagnosed and suspect porphyria, I am sending you patience. The emotional toll of going from doctor to doctor is real, and it is heavy. Please don't go to your appointments alone. Find someone who believes and supports you and is willing to walk with you every step of the way. Get second, third, fourth, fifth, sixth opinions. Take breaks to rest in between. The roller coaster of emotion for these appointments is real, but you deserve answers. And you deserve providers who will answer questions. If you are newly diagnosed with porphyria, this message is for you. Welcome to our community. We are small but mighty. I encourage you to reach out to others who live with this disease, because we learn more about daily living from our peers. And if you've lived with porphyria for a while, this message is for you. Here's a gentle reminder that rest is productive. You are worth more than what you produce, and that it's not helpful to compare where you're at with the rest of your graduating class. You have different challenges than they do, and you're on a different path, and that's okay. You're exactly where you are supposed to be. That's it for me today. I want to thank Nicole for inviting me to speak. I'm absolutely honored to share a piece of my story and be part of Patient Day 2024. Happy Global Porphyria Awareness Week to all of you. Thanks.
Okay. I hope some of you could relate with what Claire was talking about. And we had another patient and caregiver scheduled to speak today on CEP, but they weren't able to make it. I wanted to take this opportunity to talk a little bit about Porphyria Awareness Week, National Porphyria Awareness Week. One of the ways that I'm the new executive director of the APF, and I love helping patients. The way I got involved with the APF and then Awareness Week and things like that was just being part of our community. We have support groups online. Claire was bringing that up. We have Facebook support groups. We have book club. We have movie night. We have Let's Talk Porphyria Zooms where patients get together and, we just talk about things. And we have an incredible community here. And I love that everyone takes so much time during National Porphyria Awareness Week to share some materials, doctor packets that we have. Just kind of take a look at our website for the activities for this week, and talking about porphyria and about yourself, sharing with other people, it does make a difference. And And this is our time to kind of make this not as rare. I mean, it's always going to be rare, but to make people more aware of what we go through. And, you know, since a lot of our symptoms can look like other diseases, to maybe have people think porphyria. That's our slogan this year, is Think Porphyria. Ask your doctors to test you. Ask your doctors if this is something you could possibly have. And if they don't know, we have over 6,000 doctors in our database that we can send doctors in your area. And we also, like I said, we have these doctor packets. So we are here to support you to show you rare this National Porphyria Awareness Week. And I just want to commend everybody for being on this call. It's been a long one, and just by being here, you're showing your commitment. And also, I know that sometimes it's very hard to share, and I think especially during National Porphyria Awareness Week, it's hard to get vulnerable. And if you're not ready to do that, don't feel pressured to. But we have things that are easy to share, like the Click campaign that I talked about at the beginning of this of the video, and I think to me, it shows a lot when someone is so upset that they can't talk about their disease. I think that speaks volumes. So just be you, share what you can. And I'm just looking forward to a very successful National Porphyria Awareness Week. And I want to just thank everybody for being on here today. And I do want to let everyone know we're going to be having we get a lot of requests for a nutritionist Zoom. We're going to be doing that. It's not going to be during National Porphyria Awareness Week, but it will be in about a month. So keep your eyes peeled. We'll be sending it out in our e-news. And just want to thank everyone for coming again. Happy National Porphyria Awareness Week.